So today we're going to talk about nasopharyngeal airways. A nasopharyngeal airway is or otherwise known as an NPA, is a very common airway adjunct that we use in EMS to maintain patency of the patient's airway. So it is a hollow rubber tube with a bevel end at the distal portion here. It's cut at an angle. And then you also have the hub here. You have the hollow tube, and this is the measurement of how many millimeters it is for the patient. On the packaging, it's also measured in French sizes. And it also, you're able to suction through an NPA also, so that is another reason you have a French size. Some of your indications for an NPA, you have patients with their tongue obstructing their airway. The tongue obstruction of the airway is the most common obstruction for both adults and children. Children specifically due to the large proportion of their tongue compared to their airway. So here you can see where you would put it in the nasopharynx portion versus the oropharynx portion that end up meeting in the middle in the trachea. So you also have angioedema. Angioedema is a common reaction to an ACE inhibitor, most commonly lisinopril. In your population, your angioedema causes swelling of the eyes, the lips, and the tongue. And in these patients, you want to be proactive and not reactive to the patient. When you start seeing signs of possible airway compromise or airway failure, you need to go ahead and be looking at your airway management. Do I want to place an NPA? If they have any structural abnormalities in the mouth, it is more commonly preferred that you use an NPA. If they have any kind of cleft lip, cleft palate, you do not want to put an OPA in their mouth, risking of puncturing their palates. So seizures, patients with seizures, you do not want to put anything in their mouth due to the clenching of their mouth, and they bite. If they bite and clench when they're having a seizure, they can break off a piece of plastic of the OPA and swallow it, or you risk breaking their teeth and them swallowing their teeth and causing more oral trauma. Any kind of oral mass or trauma, if there is a mass in the airway or in the mouth, you do not want to disturb that mass. You want to leave it as it is and try to facilitate around that mass what you can. Oral trauma such as an assault, patient's been punched in the mouth, has some severe soft tissue bleeding due to the mouth being vascular, losing teeth from the assault and they're bleeding. Any kind of oral trauma, you do not want to place anything in the mouth, so the NPA may be a more preferred way to facilitate their airway. Enlarged tongues, some people are just naturally born with more enlarged tongues known as macroglossia. It is just a more common thing with people that just are born or have accumulated a larger tongue as they've gotten older. Soft tissue obstruction of the upper airway, whether that be a foreign body, tissue of the human body itself, just swelling, anything like that, you may just want to facilitate with an NPA. Impending airway compromise, even in medical cases outside of trauma, if your patient is showing signs of impending airway compromise, again, be proactive instead of reactive, and maybe go ahead and consider an NPA. Patients needing an adjunct airway, but they have an intact gag reflex. If they have an intact gag reflex, you cannot place an OPA, so an NPA is the better option if they have an intact gag reflex. And it can also be inserted whether your patient is conscious or unconscious. So the patient does not need to be unconscious for you to place an NPA. It is uncomfortable, but it is bearable for the patient. So some of your indications for an NPA, this is an example of your enlarged tongue, that macroglossia. This is an example of some oral trauma. The reason I consider this one is his nares are intact. Now, as far as the trauma up here, you can't see unless you do a very good patient assessment, but his nares are intact that you can possibly place an NPA. Over here you have your clinical angioedema, which is the swelling of the eyes, the lips, and inside will be the tongue. This is one of those patients you need to be, proactive and not reactive with these patients as they decline fast. Some of these cleft lips and palates may not facilitate an NPA like these two, but this one may facilitate an NPA. Some of the reasons we do not want to place an NPA, we have maxillofacial trauma. Facial trauma of the maxilla, the nasal bones like the lacrimal bone and some of the jawbone. You may not want to place an NPA. They typically have loose bone fragment, extreme bleeding behind there, and in the soft tissues, you risk puncturing more soft tissue, causing more trauma. and causing more bleeding, and you can also actually puncture their brain with it. Even though it's hollow and rubber, when you're putting in enough force, you can cause more trauma. If they have any kind of epistaxis, nose bleeding, if we go ahead and facilitate an NPA, we're gonna cause more trauma as we're placing the NPA and cause more bleeding. So we do not want to put it in a patient with a nosebleed. Nasal fractures, like we talked about, if they have a fracture of the lacrimal bone from a wreck, assault, or any other kind of trauma for causing a nasal fracture, we definitely do not want to put it in there to push any of those fragments down, pushing it into more soft tissue causing bleeding, or even pushing it into the brain. The nasal tumors, just like the oral tumors, you want to leave the nasal tumor alone. You do not want to disturb it. You do not want to shift it, move it, because some tumors are actually very vascular and bleed. Severe septal deviation, the septum of your nose separates your right and your left nair. This is made of cartilage and is very soft and malleable. So instead of it being normally medially in line, their septum is deviated either one side or the other. This can make it difficult to facilitate NPA insertion. Your basilar skull fracture is a fracture of the skull dependent on one of 4 locations. It presents with battle signs behind the ears, which is hemorrhagic bruising behind the ears, and then the bruising of the eyes that are purple in nature. This type of skull fracture you can risk because if it's fractured on the front, you can actually risk going into their brain. So this is an example of your LaForte major maxillofacial trauma. All of these loose bone fragments here, when you go to facilitate an NPA insertion, you can push all of these fragments into soft tissue. This is already probably likely bleeding and causing more severe trauma. And you actually also see their mandibles broke, and it looks like they may have attempted to fix it, or that may be their ligament trying to hold it together. But just due to this nature of this trauma, a more invasive airway management is likely to be needed for this patient. So here you have your basilar skull fractures. Depending on where the fracture is where you will see the signs, whether you will see the battle signs of the eyes, the battle signs of the ears, or the raccoon eyes. So this here is your deviated septum. This is what your normal septum should look like, and this is what your deviated septum looks like. As you can see, if you went through this nair, you're not going to be able to facilitate insertion through that nair. This is an example of the raccoon eyes and the bruising behind the ear of basilar skull fractures. Here is the different types of airway adjuncts. You got OPA, which is the one that goes in the mouth, the nasopharyngeal airway, which we were discussing in the nasopharynx, and then the LMA, which goes in the mouth and is actually more invasive. So the goal of our NPA is to be less invasive to most invasive. We want to do it as less invasive as possible if we can help it. It can also be placed kind of quickly in an emergency setting. It doesn't require as many tools, and in most circumstances, you want to do least to most invasive, but some circumstances do facilitate more invasive airway management. So if you can help it though, try to do least to most invasive, and NPA is considered more least invasive. When you get into stuff like endotracheal intubation, you're going in somebody's throat, you're placing a foreign object in their trachea, which is the ET tube, and you're getting super invasive. You risk breaking your teeth, you risk misplacement of the ET tube. And then you've got stuff here, which is like your cricothyrotomy, which is when you do a surgical airway on somebody, which is considered in EMS the most invasive form of airway management, which we want to avoid at all costs if possible. So when I said using your proactive instead of reactive for your angioedema, if you're not proactively treating your angioedema, they're probably going to end up with an invasive surgical airway due to the throat swelling, which we want to avoid. So when you measure an NPA and gather your supplies, you want to make sure you measure from the corner of the medial of the nose to the earlobe, or you can do the corner of the jaw. The diameter, roundness of your NPA needs to be slightly smaller than their nostril. That way you know it will facilitate an easy insertion. You need your lube, a properly measured NPA. You need Afrin, that is for in case you cause trauma and cause nasal bleeding due to the vascularity of the nose. You need suction equipment, whether your patient's already actively vomiting from the fact that they have a head injury or from the fact that it causes them to vomit. You need to be able to be prepared for that to reduce aspiration risk. BDM, you will need that to provide the positive pressure ventilation once we have placed the NPA to give them more higher concentrated air through the BDM. Security measures for your NPA, you follow your local protocols for whatever it says your NPA securing is, whether that be tape, whether that be leaving it, or if you have a common commercial device to secure it. And then you want to look at pre-oxygenation measures of your patient. You might want to pre-oxygenate your patient as you're preparing your NPA for insertion and all your supplies. So when you're properly placing an NPA, you want to make sure you lubricate the NPA all the way. You want to start in the right nostril first and use the bevel side toward the septum. If you cannot facilitate or meet resistance of the right nostril, you want to move to the left nostril. If you cannot facilitate it in the left nostril, you want to stop trying to place the NPA before you cause trauma and look at another airway management. You want to secure the NPA once it has been placed, and you want to try your ventilation with BDM, whether that be in between the patient's breath or breathing for the patient. So in summary, your nasopharyngeal airway is your common airway adjunct we use to facilitate airway patency. It can be used for multiple reasons, and there's many reasons we should not use it, so you need to be familiar with those reasons prior to inserting one in a patient. It must be properly measured, and all supplies need to be ready prior to you inserting it. You do not want to insert your NPA in your patient vomit and your suction is not ready, and the patient aspirates. You always try to start with the right nair unless you're unable to facilitate its insertion, and then you move to the left side. And then if you're unable to facilitate any placement of the NPA, you need to move on to a different airway solution. Once in place, you need to ensure it is secure and try to attempt ventilation. So here we're going to place an NPA. I have my properly measured NPA for this mannequin, and as you can measure it here, from the tip of the earlobe to the middle of the nose and that nair, it's already been pre-lubed. So we're going to go in bevel side here towards the septum of the nose. You're going to just facilitate its slow insertion until you meet resistance or you meet the hub. And then you have your BDM here using my CE method. Your C here with your E opening the airway and giving just enough breath to ensure chest rise and fall. And then you facilitated an NPA. So with this NPA, say you fail your NPA insertion in the right nostril, you ensure you take the bevel side the opposite way towards the left nair, and then you want to facilitate its insertion in the left side. So once it's facilitated in the left side, you can do that also. If you meet resistance with both nairs, you need to remove it and maybe consider going ahead and doing BDM ventilations until you're able to figure out your next method for securing an airway, whether that be an OPA if the patient does not have a gag reflex, or should I consider aggressive management with ET2 management, or should I do a surgical airway depending on what's wrong with my patient. And again, remember with these pediatric patients, their tongue is proportionately larger in their airway, so sometimes a mouth airway may not be the best solution for these patients, which is why we consider a nasopharyngeal airway. Your nasopharyngeal airway, again, goes through your nose into the nasopharynx, which is actually separate from your oropharynx. So sometimes this is a better solution for patients with issues with their mouth, issues with swallowing, just structural abnormalities, if they're vomiting blood, anything like that. You do not want to place anything in their mouth to aggravate those things. So a naso airway may be better. So now you can see why your measurement here to here is actually so important through the nasopharynx and its length. So where you measure it from the tip of the nose to the earlobe, you can actually see how it is able to be equivalent to your nasopharynx here. And you can get it all the way to the hub at the nostril, and then the actual whole trumpet, that hollow tube, is here, and this is what you're actually delivering your air through. When you're either bagging a patient, or when you're providing blow-by, whatever method you're using to deliver your oxygen, it's going in here, coming down, and coming into this nasopharynx, where it will eventually end up joining at the trachea, so your patients have an adequate airway management. You're wanting to make sure you're aggressive with airway management and proactive and not reactive. Airway management is the #1 part of patient assessment, so you want ABC. So you want to make sure your airway is super proactive and not reactive. You need to be aware of your patient's airway. And that is nasopharyngeal airway.